Hi, this is Professor Mulcahy. I'm putting together a really short video to show you how we do a routine shift assessment on a well baby. You'll have to forgive me if my voice starts to go out. I've been sick all weekend, but I did want to get this out to you so you'd have time to look at it. The shift assessment is briefer than the initial newborn exam that you might see right after the baby's born. Once the newborn's stable and just rooming in with mom, we only really assess them usually about once a shift, sometimes a little more often if there's something about them that warrants it. If they're late pretermers but they're rooming in with mom, or they have mom had GBS but wasn't adequately treated. In those cases we might be a little more vigilant. Now, newborn assessment requires a lot of focused attention. You can't assume anything about these babies. They're like a Jane Doe. They came in, we didn't know very much about them. Maybe we had some history from an ultrasound or from mom's health condition, something in her history or assessment. But usually we don't really know a whole lot about them until they're actually out and we can take a good look at them. So they can't tell you what's going on because they're pre-verbal, but they can show you. And if you train yourself how to look at what's right in front of you, you can gather a lot of information just by watching and listening. Okay, so before you even touch the baby, you should start to notice a few things. First, look at the baby's color. If you look at the baby in this picture, you'll see that the baby is nice and pink, including the mucous membranes. Let me see if I can kind of draw a little circle around there. When you get a good look in the baby's mouth, if the baby's crying or if the baby's yawning, take note of the color of the tongue, the color of the gums, the lips. That's going to tell you a whole lot about oxygenation in a new baby. They may have blue hands and feet. That's called acrocyanosis. If you give me a minute, I'll give you a picture of that. So here we have a picture of what's called acrocyanosis. Excuse me. And you can see that the hands and feet are kind of purpley and blue. The rest of the baby is nice and pink. Perfectly normal for the first 24 hours of age. Usually it'll clear up really even sooner than that, but all that really tells you is that the body's a smart machine, and it will shunt the oxygenated blood towards the heart and vital organs and brain and away from the hands and feet. On the other hand, if you see a baby who has blue around the mouth or worse inside the mucous membranes, that purplish color, that's a sign of hypoxia or decompensation. If the baby is all over blue or all over pale, or if we have central cyanosis, that's a sign that the baby has an oxygen deficit, and that's something we would want to act on right away. So now I'm taking you back to that nice healthy newborn who's pink. By the way, if you have a baby who is of darker complexion, they're African American, Asian, Hispanic, sometimes Mediterranean, Asian Indians, you might have to look inside the mouth again at those mucous membranes to see if your baby's well oxygenated. But there are other clues as well. If you'll notice, the baby in this picture has a nice flexed posture. That's normal tone in a newborn. In fact, if you stretch out the arms of a brand new full-term baby, they should recoil immediately. Babies like to be kind of tightly flexed like that. Now, if your baby's having problems, you'll see some differences. Give me 1 second. Okay, so here we have some images of babies who have poor tone. They're hypotonic. They're flaccid. I'll show you the first one I want to call your attention to. Let me shrink these down. Is this baby. This baby is clearly preterm. You can tell that not only by the size, but also by the thinness of the skin, the lack of subcutaneous fat, and those floppy extremities. So when you're looking at a normal newborn in a crib, you can kind of see the difference is that they should be really tightly flexed. And here we have a term baby who has poor tone, and you can see that the examiner really has to support the head to keep it from flopping back. The arms aren't flexed real tightly, the legs are kind of out. I mean, it's not the worst I've seen, but definitely low tone. And one more picture just to kind of drive that home. We've got this baby is in somebody's hands. When you put a baby in that position, their arms and legs should still kind of curl up a little bit. And this baby's real floppy, no tone in the neck muscles. And that's usually a sign of oxygen deficit, cardiac defects, neurological problems. Something is going on with that baby. On the other hand, you can see higher tone, like hypertonic babies who have either neurological damage, or sometimes we'll see that in babies who are withdrawing from drugs or alcohol. While we're on the subject of things like color and tone and things you can notice without physically examining the baby, I want to call your attention to another variation of color, and that is jaundice. Jaundice is pretty common in newborns. So let me show you a picture of that. Okay, so you'll see this baby, it's almost a little bit subtle, but when you look at the examiner's arms, they're much more pink compared to this baby who is yellow. Jaundice goes from head to toe, and it's a sign of bilirubin accumulating. Visual estimation of bilirubin is not perfect, but if you think that the baby looks jaundice, certainly you would want to follow that finding up. Most times jaundice clears up with just extra, feeding and helping the baby to stool. Sometimes we need phototherapy, and sometimes we need transfusions if it's really, really severe. I've only seen that maybe twice in my career. But if jaundice is untreated, it can lead to permanent brain damage. So it's important to start picking up on things like that. So I'm going back to our first baby because this to me is the picture of a normal, healthy newborn. The next thing that we're going to look at is work of breathing. So you want to notice if your baby is having any sign of respiratory distress. And respiratory distress in a newborn can be pretty subtle. I'm going to show a video as part of a playlist right after this video of a baby who's working hard to breathe. So you need to notice how your baby's breathing. Babies should be abdominal breathers. They should not be flaring their nostrils. If they are flaring, they're trying to get more air in to compensate. They should not be retracting the substernal muscles. You should not have seesaw respirations. The respiration should be symmetrical. And the baby should not be grunting. If you give me 1 second, I'm going to play a recording of grunting in the background. Okay, this is grunting. Now, a lot of parents will confuse that for a funny sounding cry. It's not crying at all. It's almost like nature's CPAP. The baby's trying to force more air down into the lungs. So while we're on the subject of crying, a vigorous cry is what we expect, a lusty cry. So I have a recording here. That is what a newborn cry should sound like. Okay, you'll get real used to that being on the unit. But if it's a high-pitched or shrill cry, that's often abnormal. We see that sometimes in kids with neurological syndromes or with oxygen deficit to the brain, and we also see it in neonatal abstinence, which, as you know, is opioid withdrawal for babies. So pay attention. If the baby's quiet, you can see some things, and if the baby's crying, you see others. But every time you walk into a room, you should start to notice certain things about that mom and baby. Color, tone, work of breathing, crying. Some other things that you want to notice before you even start. We talked about crying. There are really basically 3 states of alertness in a newborn. You have sleep. Let's see if we can make these smaller. Babies spend lots of time sleeping. There is the quiet alert phase. Sorry, we'll shrink you down. And quiet alert is where babies learn the most about the world. They don't spend a lot of time in it, but they will spend time. Notice also whether the parents are bonding with the baby. That's important. Are they caring for the baby? Do they seem overwhelmed? All of those things are kind of important to notice. I'm sorry, I have all these little pictures in the background. I'll get rid of them. And of course you have crying or fussy. So those are some states of alertness that you might see in newborns. So now that you've sort of taken a quick overall view of your baby, if you're ready, you can start your physical assessment. Of course, always ask mom's permission. But if your baby's quiet, this is a really good time to listen to the heart. The heart rate is the hardest thing to learn to do because it's very fast. Most people aren't used to counting that fast, and you have to count it for a full minute. So a lot of folks sort of lose their attention span. So the place where we listen for the heart rate is right here at that number 4. If you're doing an initial assessment, you can follow that pattern, that 1, 2, 3, 4, to listen over the valves of the heart, but we're not there right now. We're just talking about getting a rate and a rhythm. And in the background, you're going to listen for murmurs. So you should be at the 4th to 5th intercostal space, directly below the nipple line, or the mid-clavicular line. So it's really going to be right under the left nipple, and you're going to count for a full minute. Let me get some audio so you can have an idea of how fast it really is. Okay, here it is. Let me get that settled for you. Okay, so I only played it for about 9 seconds. I am going to attach onto the end of the playlist that I'm going to send you drum beats that are in the approximate range that a newborn heart would be. Remember that 120 to 160 is normal. Your book might give you 110 to 160, and that's okay. I have seen one book that says 80 to 180, depending on the state of alertness of the baby. I am very wary of accepting 80 as a normal value. I have never seen a baby whose heart rate was 80 who wasn't in some kind of trouble. In fact, when we do neonatal resuscitation, if that heart rate is under 100, we're bagging the baby. And when that's not enough, we can sometimes do compressions. But 120 to 160 is a good rough guide. Sometimes at rest, they will have a lower heart rate. But if you're getting values that are under 100 beats per minute, let your instructor or the assigned staff nurse know right away, because it's not normal. Now, chances are, if your baby is pink and breathing okay and has good tone, that you just miscounted, but let somebody know anyway. And you should never really be assessing a baby all by yourself anyhow. That should always be done in the presence of a nurse. After you listen to the heart, you can move your stethoscope to the axilla on both sides. You can listen posterior breath sounds. Babies might not like it. A lot of times while you're listening to the heart, you're hearing the air move in and out, but you should listen over all the lung fields. Then you can move very quickly for bowel sounds in all 4 quadrants. It's best, really, honestly, if you have a smaller neonatal-sized stethoscope, because sound is very poorly localized in these kids, and you can see there's really not a lot of room. So you'll be hearing everything all at once. It gets very distracting. So next, let's move on to the baby's temperature. It's a good thing to start this assessment fairly early before the baby's undressed and gets cold. You don't want to fall slow reading. We do axillary temperatures in newborns. 1 rectal on admission, but we really don't do rectal after that without an order, definitely not. Newborn temperatures range from 97.7 to 99.3 according to my sources. Some textbooks may vary by a decimal point or 2. That's okay, but that's really the range you want to be shooting for. If you're getting a low reading, recheck it. Or you can have someone more experienced recheck it if you'd be more comfortable with that. If it's still low, we usually place the baby skin to skin with the mom, or we wrap them in pre-warmed blankets, not just room temperature blankets, or we put them under a radiant warmer with a skin temp probe on them, and then we recheck. Sometimes a very sick baby or a preterm baby, even the late pretermers, 35, 36 weeks, just can't maintain a temperature. That can be because of sepsis. Babies' temperatures go low most of the time when they have infections instead of high. It can be because their blood glucose is low and they're using up their brown fat for the sugar instead of maintaining a temperature. It can be because they're preterm and they don't have enough brown fat. So a baby who can't maintain a temperature is a baby who needs medical attention. And it's important to know what normal is and act on an abnormal finding, just as with everything else we do. Now, if your baby was quiet, you might have counted the respirations already. But now that you're starting to unwrap the baby, babies are abdominal breathers, so we're going to look for their respirations right around where the umbilical cord clamp is. And the way that I normally do it, I have gloves on while I do it. I put my hand very gently on the abdomen right over the umbilical cord stump, and I watch my hand rise and fall over the course of a minute. Normal respirations are 30 to 60 in a newborn. Tachypnea is a sign of respiratory distress. Tachypnea, let's write that word out because people aren't familiar with it, and every time I say it, they sort of mispronounce it. But here it is, tachypnea. Tachypnea is defined as, in a newborn, breaths per minute greater than 60. So if you have a baby whose respirations are 72 per minute, that baby is tachypnic. There are a few reasons for babies to be tachypnic. One of them is respiratory distress. The other one would be overheating. So if your temp was 100.2 and your baby's respirations were 78, you know what the problem is, and you're going to make some sort of intervention that addresses that high temperature. If they're overheated because mom has 20,000 blankets on them, you take the blankets off. Anyway, babies are periodic breathers. They don't breathe in a regular, even, rhythmic fashion the way that adults might when they're at rest. They breathe sort of like this. And it really freaks parents out in the beginning because they think there's something wrong with their baby. It's not. It's just that they're new at it and they're learning how to do it. It's the immaturity of the nervous system and the respiratory system working together. So that's all normal. But remember to count over a full minute. Remember to pay full attention to that baby's breathing. While your hand is on the abdomen, you're sort of also feeling whether the abdomen is tense, but we'll kind of get there when we do the rest of it. Now we quickly move from head to toe. So let's take a look at some of the variations of normal that you might see in the baby's head. I'm going to start with molding. Okay, so this baby's head's a little bit molded. There's, sort of that cone head type shape. It's a little harder to see. You might see some bruising at the back of the head, very common and normal. Might even see a circular pattern. Let's see if I can find something that looks like bruising. Yep, there we go. So that's all really common. Just, birth is kind of rough on kids. You don't think about it. We think about the mother's pain during delivery, but the babies go through a lot too. Something else that you might see is, where is it? I know I have a picture of cephalhematoma somewhere. There it is. And it looks like that, and that is that one-sided swelling. The word hematoma sounds really awful, but it's actually fairly common. It is a collection of blood underneath the scalp. It does not cross the suture lines. You might also see caput, which is a more diffuse swelling. But all those things are pretty normal in a newborn. So we look at that. We look inside their mouths. I'm going to show you a picture inside normal tongue and picture of a tongue tie, because tongue tie is a real common thing that we sometimes pick up during a shift assessment because the baby's crying and we just happen to notice it. That is a normal tongue, by the way, that I just showed you. Look inside the mucous membranes, make sure that they are pink and moist. And here is the tongue tie. I'm going to make it real big. And you can see, this is the frenulum. The technical term for this is ankylosing, and it is caused by a tight frenulum. The significance of it is it can make breastfeeding really, really tough. And sometimes a pediatrician can cut that frenulum, and that will help the tongue move freely. Baby will be able to massage the milk ducts and will get milk. But a lot of your bad breastfeeders, look inside the mouth, you might see something like that. While you're in the mouth, check the suck reflex. A baby who doesn't suck is a baby you can't trust. All babies should have a vigorous sucking reflex, even if they're not good breastfeeders. So put your finger in the baby's mouth and you should get a response from that. So next, inspect the chest and abdomen. Now, if you're doing what I told you and you were looking at the chest rise and fall and the abdomen rise and fall while you were doing your overall appearance check and while you were counting respirations, you've already done some of this. You want to also take a look at the umbilical cord stump. And let me give you a few examples of that. Now, here is a baby who was probably born a few hours ago, and that stump is nice and moist and pretty plump. Let's put that away. As they get older, they kind of shrivel a little bit until you can take the cord clamp off, which you as a student are not ever going to do without a nurse with you, even though it's really not a complicated procedure. And you can see it's starting to dry up. Eventually it's going to look like a raisin. It's going to fall off. And that's all normal stuff. Now, if you see any redness or pus or bleeding around the base of the umbilical cord, that would be something you would want to address right away. And if you see something that looks like this, and this is another thing that you might find on a routine shift assessment only because, oh, no, sorry, that wasn't the thing I wanted. Because when the baby's riled up and is crying very vigorously, you could see it pop out. That's called an umbilical hernia. Let me take a There you go. You can see that bulging. That's caused by the intestines kind of slipping through a weakness in the abdominal wall. It can sometimes resolve on its own and sometimes need repair, but we do need to make sure that the physician's aware. He's going to check it further, decide what to do about it. The one thing that you want to educate the parents to do is not to tie it down or try and, some cultures want to put a coin on it or something like that to reduce it. You do not want them to do that because that hernia can become incarcerated. So anyway, that's an umbilical hernia. Okay, so while you're still on the upper half of the body, you should have noticed the baby's tone. Like I told you, you can check for palmar grasp reflex. You put your finger in the baby's palm, and they usually reflexively just wrap their tiny little hands around it. And parents love this. It's, oh, he's holding on to me. We like it too because it means their nervous system is functioning the way we want it to. Then you can do a moro or startle reflex. I'll try and find something along those lines. Okay, so here you see a still picture of somebody trying to elicit a moro reflex. I tried to get video into this app, by the way, and sometimes it'll play the audio but not the visual picture, so it was kind of frustrating. Anyway, you're going to see a lot of moro reflexes if you're hanging around the unit. So that's another reflex you can test. Parents don't like this one as much because the babies, look like they're flailing and they get very protective. So warn the parents before you do it and they won't hate you as much. While you have the baby undressed, I want you to look at the skin. There's some normal variation. Postdates babies have some drying and cracked skin. You can see Mongolian spots. You'll see so many of these I don't even want to stop to get pictures. But I do want to show you a picture of newborn rash. So let me see if I can find that. So here are some pictures of newborn rash. It's also known as erythema toxicorum, but do yourself a favor and do not refer to it as anything other than newborn rash while you are talking to a parent. It looks plain awful, especially on the lighter skinned babies, but very, very common. It's just because their skin is so sensitive. They've never been exposed to any of the stuff, really. They've been in utero with vernix. Generally, they've been exposed to amniotic fluid, but not to anything else. So it's reassuring. Okay, so while you've got your baby undressed, you're going to elicit a Babinski reflex, and I'll show you how to do that. Because I can't get video, it's almost pointless to put even a picture up, but you're going to stroke the baby's foot from the heel to the toe, and the toes should fan out. Now, in a newborn, this is very reassuring. In an adult, not so much. But in our babies, it tells us nervous system is functioning. You can also elicit what's called a plantar grasp. You press, usually with my thumb I do it, in the sole of the foot, and I watch the toes curl, and that tells me, again, that the baby's nervous system is intact. Next, you open the diaper. So if the baby's a girl, it's normal to see a little mucus or even a tiny drop of blood in the diaper. It's called pseudomenstruation. All of it's normal, and it's in response to mom's hormones. You're not getting any pictures because I think that violates child pornography laws, but just know that those things can happen, and we will see it live in clinical plenty of times. If the baby's a boy, he may be intact, he may be circumcised. If your baby is circumcised, check for bleeding or swelling and use this time to reinforce your teaching. Immediately after circumcision, you might see a drop or two of blood. It's never more than the size of a dime. If you see it oozing or dripping, or if you see more blood than that, you should take a clean 4x4 and apply direct pressure on the site. Of course, if you're assessing a baby, there should be another registered nurse right next to you, either your instructor or a staff nurse, and they'll know what to do. You just should know that that's the correct action to take. If you see active bleeding, a lot of times direct pressure is the answer, whether it's a surgical patient or whatever, but let's not get too sidetracked. The day after circumcision, it's very normal to see yellow granulation tissue. That's a sign of healing, but it looks a little weird, so moms might think it's a sign of infection. If you educate them right after the circumcision, you kind of head that off. The parents should be putting Vaseline or A&D ointment on a gauze square and covering the circumcision site with the gauze to prevent the penis from sticking to the diaper. That should happen with every dressing change. And it also keeps urine from stinging. As far as the contents of the diaper, initially the newborn has dark tarry stool known as meconium. Give me 1 second. So that's meconium, that's the first stool. It's very sticky, it's hard to get off, it sticks to the scrotum, it sticks to the legs, sticks to the labia, so it's so much fun changing a baby when they're brand new. Most of the time what you should be doing. You can do it, but you should be teaching every time you're doing it. Baby girls get wiped from front to back. Baby boys, you just got to watch that you're removing all the stool. In a day or two, actually it's more like 2 or 3 days, the stool should transition. Breast milk stool will get yellowish, more seedy. It smells a little more like sour milk or buttermilk, I guess. It's got curds in it. Formula fed stool will be more like an adult's consistency. It'll smell kind of more like what we associate with poop. It'll be browner. It'll be a little firmer. Let mom know that the soft consistency of a breast milk stool is not diarrhea. She should not be concerned. What diarrhea does look like in a newborn, it's a watery stain on the diaper, like greenish water. Sometimes it might even be a little more brownish than greenish. But a mushy breast milk stool is not diarrhea, so she should not be concerned. When you're finished, you put the baby in a clean diaper, dress the baby, swaddle them, or put them back to mom. They should go right back to being that baby that we saw in the first picture. There. And you are done. Record your findings. If you guys are on nights with me, you'll get weights, but that's a whole separate thing. So I'm going to put this up on YouTube, and there'll be a video to follow with a baby in respiratory distress, so stay tuned for that because that's kind of an important concept.